Hi, my name's Jackie Buckthorpe, and I am one of the critical care paramedics working with the pre-care team. This lecture aims to give operational and practical context to our series on physiology guided or targeted CPR. You've heard from Nat on the value that having a physiology guided mindset can bring to your cardiac arrest management, whether you're managing a patient who ultimately goes on to require pre-hospital ECMO or not. The goals of care remain similar. We know, and I'm sure that you do too, that the first 15 minutes of every resuscitation probably matter the most. And therefore, what paramedics do matters, and it has the potential to have the most impact on whether a patient walks out of hospital neurologically intact following their resuscitation. You've heard in detail from Nat the importance of getting the basics right and paying meticulous attention to detail in the provision of excellent ALS. My role is to give some context from more of a paramedic perspective. The paramedic perspective and how to implement a clinically focused, physiologically structured approach to cardiac arrest is something the pre-care team has spent a lot of time developing. These charts are an example of a resource that's been created for the CCPs and the critical care doctors in our pre-care team to utilise as a framework for debrief. We use the goals of care that we spoke about in previous lectures to guide our debrief so that we can ensure we're all on the same team as to the priorities for the individual patient pathology we were treating. We also spend some time talking about specific treatment options for these patients, depending upon the etiology of their presentation. But what does a physiology-guided approach look like in practice? And how on earth do we incorporate this perspective without losing sight of the algorithm, the checklists, and the workflow that we've trained and that we've built up within our workforce? We are already inundated with algorithms, checklists, workflows that have served as incredibly efficient tools for pit crew resuscitation and also high-performance CPR. Paramedics have a well-deserved reputation as pre-hospital resuscitation specialists. So what does this additional layer of physiology-directed CPR education offer us? Does it replace the algorithm or any checklist? Well, no, of course not. This package is designed to support the application of these tools, to allow you to tap into your clinical knowledge and your expertise to remind yourself of the importance of getting the basics right, and furthermore, to explore how we can assess the effectiveness of our interventions in real time. We know that cardiac arrest patients are dynamic, and rather than hammering a dynamic and changing pathology into a one-size-fits-all algorithm, we must consider using the algorithm and our underpinning clinical knowledge to meet the specific clinical needs of our patient. We've spoken about the heterogeneous nature of cardiac arrest and how it's a dynamic pathology. We know it is fundamentally important to utilise the cardiac arrest algorithm as provided in international, national and local guidelines. This algorithm is the scaffold on which all of our management is built. You can see that the physiologic goals of care that Nat has discussed previously are ensconced super happily within the algorithm that has been lifted directly out of New South Wales Ambulance Clinical Practice Guidelines. As a reminder, the goals of care are establishing oxygenation, driving forward flow with appropriate and targeted compressions, optimizing cerebral and coronary perfusion pressure, and in that ensuring pad placement for optimization of defibrillation vector. But how do we actually do this? How do we simultaneously approach the algorithm in an efficient and stepwise manner, but also ensure that we're achieving the goals of care for this particular patient? The answer is, and the good news is, you're probably already doing it. Those patients who during your resuscitation get an early ROSC or remain in persistent VF with clear signs of life, gasping, CPR-induced consciousness, eye movements, these are signs that your resuscitation is on point. You are achieving the goals of care and providing patients with the blood flow, the oxygenation, and the perfusion pressure that they require to optimise their chance of enduring ROSC. But how do we quantify these skills and these interventions, ensure that we're doing it every time, for every patient? I think we need to have a pre-thought out structure, and that clinical thought structure, process, and leadership must start even prior to meeting the patient. En route, you'll have access to some really pertinent information available to you to help you guide your initial assessment. Whilst we all know call taker information, and therefore the information on your MDT, must be taken with a grain of salt, it remains a vital piece of the puzzle to consider prior to your arrival. In addition to discussing role delineation on arrival, information around clinical priorities can be interrogated from the NDT. What time was the call made? What time is it now? Therefore, what is the potential low flow time? What was the original call for? Was it unresponsive or it was a witnessed arrest? Was it for chest pain, trauma, other causes? What time did bystander CPR, what time was it stated to be in progress? Is there an AED and did that shock? What is the first crew's ETA? What is your ETA? Whilst this information must be verified on arrival, it gives us a head start on potential mechanism of cardiac arrest. It gives us an idea of no flow time, of low flow time. It gives us an idea whether the patient has added any ventilation during bystander resuscitation. And this allows us to prioritise some of our clinical management on arrival. For instance, if you are en route to an otherwise healthy young 20-year-old male who's just had 3 AED shocks, you might be considering primary dysrhythmia in refractory VF, and you might remind yourself of the importance of checking pad placement for this patient, more so than you would for others. If you are en route to a potential opiate overdose, now receiving CPR, you might be considering attending to oxygenation as an earlier priority, more so than other patients. If you are en route to a 60-year-old male with a history of ischemic chest pain and now in refractory VF in the care of another crew, with no ROSC for 10 minutes, you might be considering prioritising adrenaline to assist with coronary perfusion pressure to generate the ROSC. All of these patients obviously need your standard approach and your initial management. High performance CPR and early defib are the mainstay of treatment. But you can see that if you start your clinical thought process early, even en route, you can get a sense of the elements of your management that may need to be prioritised. Remembering that when you first arrive on scene, depending on resourcing factors, you or your partner may have a role as resource 3, and you might be required to relieve the compressor or assist with other identified urgent tasks. But if you are arriving as a clinical leader, your role should be to ensure that not only is the algorithm practically ongoing, but that the physiologic goals of care are being met. To do this, we are advocates of the scan. Now, this is an efficient, targeted, and verbalized visual scan of the patient, specific to the goals of care. Remembering the goals of care again are to ensure adequate oxygenation of the patient, ensure appropriate and targeted compressions to generate organ support and forward flow, prioritize perfusion pressure, and ensure appropriate pad placement for optimization of defib vector. Now, the order in which you apply the scan, as a leader of an ongoing and appropriate resuscitation, will depend on what you find as your clinical priorities. Think back to our discussion on the various cardiac arrest phenotypes we considered when we were en route to this job, i.e. a focus on oxygenation in presumed hypoxic arrests, pad placement for potential primary dysrhythmias, adrenal administration for refractory ischemic arrests. All of the elements of the goals of care are clinical endpoints that are already being addressed by the algorithm, but with a clinically focused leader who strategically highlights them, they can be truly optimized. When you arrive, we want you to imagine standing at the foot of the patient with the resuscitation ongoing. The first part of the clinical scan will often be ensuring the patient is being adequately oxygenated. In reality, and using a language that paramedics are typically used to, oxygenation requires us to consider the effectiveness of both airway and breathing simultaneously. The importance of this cannot be understated, especially when we consider the point in time at which we are usually meeting these patients. Most often, these patients have had a prolonged period of bystander-only CPR and no supplemental O2, or even no ventilation at all prior to the arrival of the first emergency resource, often up to 10 minutes into the patient's low flow time. Securing an airway, ventilating, and oxygenating need to be a high priority when you consider the physiological phase of cardiac arrest. Anecdotally, on the road, and likely due to a combination of factors, it seems as though we've lost the focus on the P in CPR. In the rightful push to encourage bystander compressions, or even compression-only CPR, we seem to have sent the message to professional resuscitationists that we can wait on the pulmonary part of the resuscitation. In our quest to have exactly 2-minute cycles of compressions between rhythm checks, we seem to have cut the corners on oxygenation. Perhaps it originated in the fear of airway or ventilation during COVID that's had a hangover on how we approach things now. But irrespective of the reason, it's important that our clinicians' focus is on highlighting the importance of adequate oxygenation for these patients. The purpose of these lectures are definitely not to tell clinicians which airway adjunct to use, because patients are heterogeneous and you guys know as well as I do that there's so many things to consider when making this choice. It will depend on the staffing combination you have on scene, the complexity of the airway, the patient's physiology, and the clinical prioritisation of interventions. As a leader at a cardiac arrest, doing the scan is an opportunity to not only ensure this patient is getting optimal care, but also to provide real-time paramedic mentorship as they make complex decisions around airway management. Regardless of the adjunct of choice, the scan must focus on efficacy. Not the traditional, "Are you happy with the airway?" question, which invariably results in the poor paramedic at the airway nodding at you in their effort to please, but doesn't truly reassure you that the airway is working, and most definitely doesn't assist in anyone's education. Instead, the scan should utilize specific and targeted questions. Some of the questions we'd like to consider are along these lines. Is the iGel seated? Can you hear a leak? Do we have end tidal in the circuit? Can you show me the waveform? What is the trend in the number? Has there been any change in patient colour since you started ventilating? Do we have a SATS probe on? Is the gut expanding? Have you listened for air entry? What can we do to troubleshoot this device? Do you think we need a different adjunct? Are there patient factors suggesting we might need to intubate this patient? Do we think this device is ventilating with the increased intrathoracic pressure generated by compressions? I'm sure there's more, but the important part here is to be specific in your questioning. And by considering all of the above factors out loud and sharing your mental model with the team, you will have not only gained access to the information, which will be pertinent to you making decisions around how to oxygenate your patient, but you will also have shared that information with the team so they can assist you in your problem solving. Next, we move to ensuring organ perfusion with forward flow. Traditionally, this would be C for circulation, which it still is. But let's not overcomplicate things. What we're talking about here is simply effective compressions. In practical terms, there are probably two main components to ensuring we are achieving what we set out to achieve with our compressions, which is forward flow of circulation and consequent adequate perfusion of the coronary arteries and the brain. The first component is easy to assess. It is well known and supported by guidelines. We need to compress the chest at a rate of 100 to 120 beats per minute at a third of the chest depth, and we need to ensure we minimize interruptions and pauses to have a compression fraction above 80%. More recently, the most practical and robust way that we know that we are achieving this is to utilize the CPR feedback puck, which is now mandatory in our service. This will not only allow for real-time feedback and fatigue technique monitoring, but will also help our organisation collect the data required to optimise future cardiac arrest strategy. The second element relates to some of the anatomy and physiology you heard about in earlier lectures, and the importance of ensuring that we are actually generating forward flow, i.e. we are compressing the left ventricle, not the left ventricular outflow tract. Now, when I first started learning about forward flow assessment and the work investigating area of maximal compression, I found it fascinating and incredibly motivating. But to be honest, I also had some skepticism. What on earth does a paramedic, without the luxury of a tow probe, do with this information? And at this stage, the jury is still out. But what we can say is that if we return to basic principles and the concept of assessing the efficacy of our interventions, we would want to know if our compressions are perfusing our patient. We would need to ask ourselves how we might go about gathering evidence to convince ourselves that the compressions are currently being effective. Now, with regards to the evidence at this point in time, there is limited to none to support any one clinical marker in isolation, although a strong end-tidal CO2 trend is likely useful. But our experience, seeing a lot of cardiac arrest on the pre-care car, has taught us the value of gaining as much clinical information as possible to help complete your picture. The clinical perfusion scan should include the following questions to the team. Do we think we're getting forward flow and are we perfusing the organs? Have we got any signs of brain perfusion? Any CPRIC? In the case of mechanical CPR, has the patient's physiology since we put the mechanical device on? Has it changed for the better or for the worse? Can you feel or break your pulse? Could you before? Are we getting a pleth on the SATS probe? What is the patient's colour? And has that changed throughout the resuscitation? Paramedics should feel encouraged to put a SpO2 probe on to detect any sort of meaningful distal perfusion. We would also advocate for a non-invasive blood pressure cuff throughout the resuscitation. In instances where a medical team is on scene, an arterial invasive blood pressure line will be placed to more closely assess blood pressure intra-arrest. We need to remember that what paramedics do in the first 15 minutes really matters. If there's no forward flow, no effective compressions, neurologic outcomes are likely to be poor. There is so much more exciting research to come in this space, but at the moment, simply remembering that compressions are not a set and figure intervention is vital, and we are building a framework against which to measure or consider efficacy in the future. Now, moving on to perfusion pressure. Remembering, you are still leading this arrest. You're vocalizing the clinical priorities to the team, whilst the algorithm is being performed. The heart needs a perfusion pressure to get ROSC. In a previous lecture, we considered the association between diastolic pressures greater than 25 or 30 millimeters of mercury and increased rate of ROSC. Whilst there is academic uncertainty around the optimal dose, timing, and the route of administration of adrenaline, there is no uncertainty in our guidelines. So it's important for paramedics to ensure patients are getting early adrenaline to increase perfusion pressure and hopefully get an early ROSC. Within the scan, the clinical leader should verbalise the importance of prioritising vascular access and medications being drawn up efficiently to aggressively chase a ROSC. Statements such as, while we are managing the oxygenation and perfusion, we need to ensure we optimise perfusion pressure to give them the best chance of responding to the defib and getting a ROSC. I want to allocate a person to both vascular access and someone to medication management, because the priority is getting this patient's perfusion pressure up. If there's a medical team on scene, consideration may be given to other vasoactive medications such as vasopressin, targeted adrenaline dosing, or different administration routes to support the perfusion pressure. They're likely to place an arterial line for real-time blood pressure management and targeted interventions. Finally, the importance of assessing pad placement and adherence cannot be understated. Ideally, they get placed in the correct vector in the first place, but this is something that can be rushed due to the competing pressures on arrival of the first teams. As a leader throughout the arrest, especially in a patient who is refractory to defibrillation, pad placement must be reassessed to ensure optimal vector and contact to increase the likelihood of successful defibrillation. So thank you very much for listening. Hopefully this last lecture has brought a little context to the physiological concepts that have been discussed throughout the series. Hopefully you can consider the goals of care at your next cardiac arrest as you build a physiology-based approach to cardiac arrest management into your repertoire. If you have any feedback or questions, we would really love to hear from you. Thanks again.